Hello, my name is Joseph Ghitis, and along with Irahisa Cabral and Collette Robbins, we bring you a presentation on Pheochromocytoma. The learning objectives are identifying at-risk populations, talking about the pathophysiology and pathogenesis, describing the presentation and clinical manifestations, and lastly, recognizing and discussing the anesthetic risk factors considered with the management of pheochromocytoma. Pheochromocytoma is a rare catecholamine-secreting tumor that arises from the chromaffin cells in the adrenal medulla. 15 to 20% of the tumors are extra-adrenal in origin and are referred to as paragangliomas. Both forms of tumors are referred to as pheochromocytoma due to the excessive catecholamine secretion. It often affects adults between the age of 30 to 50. Pheochromocytoma tumors release hormones that regulate vital bodily functions but at a much higher rate. Depending on the tumor size, pheochromocytomas may release norepinephrine and epinephrine. Only 50% of the patients present with symptoms. Paragangliomas that arise in the head and neck do not secrete catecholamines, and the patients will present as asymptomatic. Pheochromocytoma and paraganglioma tumors are sporadic and occur randomly with no known cause. They are often discovered incidentally due to imaging studies being performed. Approximately 40% of patients have the disease as part of a family disorder. These hereditary tumors are usually present at a younger age than the sporadic neoplasms. Symptoms are intermittent or sustained depending on the release of norepinephrine, epinephrine, or dopamine. Episodic symptoms may be triggered by stress, position change, manipulation of the abdomen or tumor, pain, or medication. Symptoms include the classic triad of diaphoresis, palpitations, and headache. Patients also often experience flushing, trembling, orthostatic hypotension, pallor, and anxiety. The clinical manifestations of sweating, severe headaches, and hypertension are similar to those of many other conditions. Anxiety, palpitations, diaphoresis, and headaches are often linked to the excessive hormones that are being released into the bloodstream. Other less common manifestations include nausea, abdominal pain, constipation, and vomiting. Organ systems potentially affected by the disease progression may include neurological, neurological, and cardiovascular. Due to the ambiguous nature of the disease, diagnosis is difficult and is often accidentally stumbled upon in later stages of illnesses like heart failure, stroke, ketoacidosis, or valvular disease. Anesthetic risk factors are much higher for patients with unrecognized pheochromocytoma who are undergoing anesthesia for unrelated surgery. The mortality for these patients is as high as 80%. Pharmacological management usually begins 7 to 21 days prior to surgery and includes medications such as phenoxybenzamine, prazosin, or doxazocin. Management involves establishing preoperative normotension and sinus rhythm. The goals for anesthetic management are a smooth induction with adequate depth of anesthesia to prevent a hypertensive response to endotracheal intubation and close communication with the surgeon to allow anticipation of events likely to cause hemodynamic instability. Patients often exhibit labile blood pressure, arrhythmias, and tachycardia during and after surgery. Beta blockers are commonly used for the treatment of hypertension and tachyarrhythmias. However, independent use should be avoided since unopposed alpha adrenergic stimulation can lead to vasoconstriction and a hypertensive crisis. Transient postoperative hypotension is common due to the downregulation of alpha adrenergic receptors, residual effects of long-acting antihypertensive medications, or hypovolemia. Hypoglycemia can occur intraoperatively or postoperatively because of a rebound increase in insulin secretion. Glucocorticoid replacement should be considered for bilateral tumor resection patients. In conclusion, the diagnosis and perioperative management of pheochromocytoma is an evolving process. Pheochromocytomas are often discovered incidentally during imaging unrelated to the adrenal gland. Patients with pheochromocytoma present a challenge in the area of anesthetic management, and a variety of techniques and medications can be used for induction and maintenance of anesthesia. The anesthetist must be prepared for various abnormalities associated with any adrenal mass surgery.